The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be able to spend some time with Dr. Rajiv Iyer from the Department of Pediatric Neurosurgery at Primary Children's. And I'm really looking forward to talking to him because he's got a unique perspective because of unique training having to do with issues, tethered cord, spina bifida, and scoliosis. So welcome to the podcast, Rajiv.
Thank you very much for having me, Paul.
So I see in reading up about you that you did your neurosurgery residency at Hopkins, right?
That's right.
But then you're double fellowship trained. It's kind of an interesting training because you did pediatric neurosurgery at Utah.
That's right.
But then you did a spinal deformity fellowship through orthopedics at Columbia. Is that right?
That's correct. Yes. So just the 9 years of training. That's it.
just 9 years of training. So yeah, you have spent a better part of your life doing this. So where did you go to medical school?
I went to medical school to NYU. So
okay.
I'm a New Yorker at heart and grew up in Connecticut, but sort of a transplant here in Salt Lake City, which is really refreshing and fun to be out here, but spent a lot of time on the East Coast.
I think people usually refer to Salt Lake City as the New York City of Northern Utah. So
that's great. Absolutely.
Are you from New York originally?
I was born in Queens and grew up in Connecticut. So yeah, a lot of time on the Northeast. And
you certainly are.
Yeah, so a good amount of time in New York City. So I was able to go back just as the pandemic was dying down and then came back here. And so a lot of cross-country moves to do all that training, but I think it was really worthwhile. And I'm super happy to plant roots here in Salt Lake and have been in practice for about 3 years now.
So 3 years back in Utah. So
That's
you did your fellowship here, then you did another fellowship in New York, and then back here.
Yeah, okay. There's few opportunities for neurosurgeons to train in spinal deformity. And so you really kind of cross lines and train with orthopedic surgery, which is great. It's a really nice marriage of the two subspecialties. And I gained so much insight from my mentors in orthopedic surgery. So I'm very grateful for that opportunity.
Well, given the breadth of your training, so we're going to spend a lot more time with that in a couple of weeks, because I think that you bring a fascinating perspective to scoliosis that I just hadn't thought about before.
Thank you. Yeah, it's an interesting vantage, and I'm excited to talk about it.
We're going to make people wait for that, though. So tune in 2 weeks. But today we want to talk some about spina bifida. Before we do you have any conflicts to disclose?
No conflicts of interest, no disclosures.
All right. So let's talk a little bit about spina bifida. Can you just refresh our memory? I think we all have studied it before, but put it in perspective for us. What happens with spina bifida and what are the subtypes?
Absolutely. So the way we think about spina bifida, it's a really big umbrella term. Spina bifida is the Latin for basically an open spine, but that refers to the bony spine. So the posterior arch of bone, literally if you touch your spine, you feel your spinous process. That's the bony prominence you feel. In certain areas of the spine in patients with spina bifida, that just doesn't exist because the arch of bone is incomplete. So there's two basic types of spina bifida. There's open spina bifida, which I think we often connotate with what that means, which is myelomeningocele. And then there's closed spina bifida, which is called another term, occult spinal dysraphism, or closed spina bifida, where the skin is completely covered and there's no actual body wall defect. And then there's some subtypes in there and it gets into the nuts and bolts, but that's the basic umbrella term. For most individuals thinking about spina bifida, they're talking about myelomeningocele, which is one of the more common body wall defects that we see. It's about 1 to 2 out of 1,000 babies that are born across the world. So with folate supplementation, things like that in the United States and North America and the developed nations around the world, there's been a big effort to include folate supplementation in grain and flour and things like that. It helps to decrease the rate to maybe 0.5 out of 1,000 births. Here in Utah, we see a good amount of it.
There's kind of a staggering public health success, though, isn't it?
Absolutely. And there's been a worldwide effort And people in North America have led that effort. We had a visiting professor recently from Alabama who really led that effort across the world as a global initiative to help with folate supplementation, and meeting with pediatric neurosurgeons around the world in various countries and developing nations. They've been successful at implementing this type of global health strategy to help reduce the rate of spina bifida because it really is a chronic disease and there's really no reversal of it. And so we follow these children. We're lucky here in Utah because we have a wonderful multidisciplinary spina bifida clinic, but we really follow those babies from even prenatal, right? Prenatal counseling all the way up into the adult years when they transition, when they're around the age of 18 years, they transition into an adult spina bifida clinic that we have. So it's sort of like diabetes or heart disease,
Yeah.
but you're born with it and you have it all your life. And so if you can stop it before it occurs with things like folate supplementation and increased education across the board, that's very helpful.
Yeah, it's huge. And such a simple intervention, which is not terribly expensive. It's the sort of thing that makes a lot of sense as a world
Absolutely.
program. You said that we have a fair amount in Utah. Do we have more than the average?
That's a good question. I'm not sure exactly. I don't know if that data exists. It
Uh-huh.
feels like it because we take care of a lot of it. But as you can imagine, there's sort of going to be some geographical differences and demographic differences that lead to that sort of discrepancy between states, maybe, depending on the populations that we serve.
What are the effects on the neurologic system of having a spina bifida?
Yeah, absolutely. So the way I think about spina bifida, and I'll speak specifically about myelomeningocele for starters,
Hmm.
is that I group sort of what we see in terms of the brain and the spine. And so I'll start with the spine because it's spina bifida after all. And what's going on is that the neural tube, if you think back to the embryology days in medical school, the neural tube actually starts as a plate. And the plate, it's like you're holding it out in space, has a little groove in the middle, and your two thumbs on the sides, if you're holding your arms up, like you're catching raindrops, your two thumbs will fold up and form a tube, literally. And that's called neurulation. And this is what has gone awry in spina bifida and myelomeningocele. So the tube didn't form properly, but it's not just the tube that didn't form. It's also the superficial tissues and the bones that didn't form properly. So everything is basically splayed out like a book. Your spinal cord, your dura or thecal sac or meninges, those are all the same term basically. Your muscle and fascia and your bones and your skin. And so none of that closed up like a book, like it should have. And as a result, there's what's called a two-hit hypothesis, where the spinal cord is basically exposed to the intrauterine environment, which is thought to be toxic to the spinal cord, which is part of the reason why fetal intervention may be successful in some of the issues that arise. But because the spinal cord is exposed, we think that it's normal in its functioning up until the anatomic level at which the spina bifida occurs. So it can be in your thoracic spine, or it can be at your L1 level, or it could be at your S1 level, right? And so, based on where it is in the spine, that's where we think you may or may not have function that's normal. So, if you're a thoracic level myelomeningocele patient, you probably would not be expected to walk. You may be paralyzed in your lower extremities. You may not have any sensation. And obviously, bowel and bladder functioning, which is your sacral innervation, will be affected. And as you go down the spine, we have sort of different metrics we use to say whether we think you'll be an ambulator. And you could be a marginal ambulator. You might be an L2 level or L3 level myelomeningocele patient. You may not be expected to walk, but around your house, you might be able to get around, but maybe not in the community. So there's a big difference between a marginal ambulator and a community ambulator. But that's what's going on in spina bifida, is we expect the spinal cord to be normal in its functioning up until the anatomic level.
In simplistic terms, it's a spinal cord injury that
Exactly.
we treat like other spinal cord injuries.
That's absolutely right. And so, and that's pertaining to the spine and the spinal cord. Then there's the brain, because the difference between open and closed spina bifida is that with open spina bifida, there's an egress of cerebrospinal fluid or CSF coming out of your back. And so as a result, there are secondary differences that you can have intracranially with brain structure and function. And that can include what's called, many of you might have heard of, a Chiari malformation, right? So a descent of the cerebellar tonsils. But in Myelomeningocele, it's different from the traditional Chiari-1 malformation. You might get an adolescent with bad headaches that are worse with Valsalva or laughing or crying. That's a very classic symptom of a Chiari-1. Myelomeningocele patients are what we classify as a Chiari-2 malformation, where not only the cerebellar tonsils, but also the brainstem are sagging down through the foramen magnum, or the hole that communicates between the brain and the spinal cord or spinal canal. And so as a result, there are differences that you might see in the small population of spina bifida patients that can include brainstem dysfunction. So stridor or difficulty breathing or trouble swallowing. That's a small fraction of patients, but it's possible. And that's why we counsel families about this. But then the obvious other issue that can occur in the brain, it almost goes hand in hand, is hydrocephalus, the Latin for water on the brain. So because of the Chiari malformation, we think that the pathways of CSF absorption are immature and CSF can build up. And therefore, you can get hydrocephalus. And that means that fluid builds up in the brain, and we treat that with various techniques. There's two techniques we use to treat that, just to mention briefly, is a ventricular peritoneal shunt, some type of CSF shunt, or an endoscopic procedure called an ETV, or endoscopic third ventriculostomy. Now we've added another component of that sort of alphabet soup, but it's called an ETV CPC, which adds a choroid plexus cauterization to decrease the amount of CSF you produce. So that's a non-device associated, you don't implant a device. That's another procedure we treat hydrocephalus. So that's how I think about spina bifida. You have brain findings and spine findings.
Just to clarify in my mind the treatments for hydrocephalus. In the one instance, it's sort of like a pop-off valve so that you can send the fluid somewhere else. And then in the second procedure, the primary goal is to decrease the amount of fluid that is produced, or is it more than that?
That's probably the secondary goal. The primary goal is it's sort of like an 18-wheeler is across I-15. And so cars can't get through. What we're doing is that's basically the concept of obstructive hydrocephalus. But what we're doing is opening multiple exits so that CSF has a way to get out and bypass the obstruction. And so we're making a hole in an area called the third ventricle. We use an endoscope to do that. So it's a camera assisted, minimally invasive procedure. We make that hole. CSF can theoretically get out, but the caveat is that the child has to be able to absorb the fluid on their own. It has to be able to be absorbed back into their bloodstream. So if they have a meningitis, or if, this is a different example, but a premature infant with hemorrhagic hydrocephalus, their absorption mechanisms are less mature. Mm-hmm. And so that's why the success rate of the ETV CPC procedure, and the CPC, by the way, adds maybe 5 or 10% of success, we think, is that the success for a newborn infant at term for treating hydrocephalus with this procedure is about 50 to 60%.
Okay. All right. You mentioned before the impact of folate supplementation in decreasing spina bifida. Are there other factors that we should be aware of that contribute to the development of spina bifida?
There's certain risk factors. If you yourself have spina bifida, if another member of the family, if you've had another child with myelomeningocele or open neural tube defect, you're at a higher risk of having another child with that. Other things like obesity, type 1 diabetes, and certain medications like anti-seizure medicines can predispose this condition as well. And so that's why we screen for it.
So certainly wouldn't ask it, especially without the age of chalk on a blackboard diagramming all this. But how much do we understand about the pathways that make that happen?
We understand it a little bit, but it all has to do with folate metabolism. And I'd have to go back to the textbooks to quote you all the exact stuff, but we have a pretty good understanding of that. We think that the medicines that sort of affect this, like valproic acid or tegretol, might have an effect on those metabolic pathways, all related to folate.
But folate's the final common.
Yeah, folate, exactly.
Interesting. So a fair number of patients who have spina bifida are diagnosed before birth. Right. Through various screening things, both AFP and ultrasound.
Yes.
In addition, are there other genetic disorders that may be lumped with spina bifida?
Yeah, there are some reports about higher incidence of trisomies, trisomy 13, trisomy 18. There's a bit of a higher risk of that if you do have an open neural tube defect. So that's why many pregnant women with a baby and fetus with an open neural tube defect may undergo an amniocentesis to check for these things.
Okay. of that group, obviously, if you know that a baby has spina bifida before myelomeningocele before delivery, tell me about the interventions that are done fetoscopically for those babies.
Absolutely. So it all starts with a visit to our fetal center typically here. And that's been an amazing success at our hospital, I think. And, it's been wonderful to be a part of that because that's sort of the latest and greatest in fetal care in terms of it's the one fetal neurosurgical intervention that we have is to repair the spina bifida while in utero. So there was a trial that occurred about 20 years ago, and it was called the MOMS trial, and it compared prenatal repair of the myelomeningocele to postnatal. And basically, the endpoints had to do with the treatment of hydrocephalus, right? So whether the baby needed a shunt or if they died, right? So fetal demise. And so the trial was stopped early due to the efficacy of fetal intervention, right? And so the type of intervention we're talking about is what's called an open repair. So the uterus is sort of brought up out of a regular fan and steel incision typically, and we work through the uterus and hold the baby in place and we do the repair. It's really a quite fascinating operation to have been a part of here in Utah. It's truly remarkable. And then you put the baby back into the uterus and close up and you close the hysterotomy and but this is the sort of principle of the surgery, right? And centers have come up with advances over this technique. That's the technique that the MOMS trial studied is open repair.
Mm-hmm.
And it should be noted that what the results of that trial are. So about 50% less shunting is one of the main outcomes of that trial, right?
Wow.
The need for a shunt is cut in half unless you present with very large ventricles in your brain already, right? That's how we kind of stratify things. So it's really important for families to know this when we counsel them in the fetal center, right? And the reason why that occurs is because you're closing the back and the baby's relying on their own mechanisms to deal with the CSF. And it also results in a reversal of the hindbrain herniation or Chiari2 that occurs. It occurs sort of in utero. And so we see that. And then the other outcome is an improvement in motor scores. So if you look at the 10-year outcomes or so, 8 to 10-year outcomes, which was from the MOMS 2 trial, they followed these children, and the original was up to about 30 months. And then we followed them into the sort of later childhood years, not adolescence, but later childhood. And there was a 2 times rate of ambulators in the fetal group, right, compared to the postnatal cohort. So really a significant, and there's also some evidence for improvement in cognition as well. So this is the backdrop, right? So this is why we pursue, because the downside is a maternal risk, right? There's a risk, and then also the fetal risk is the risk of prematurity. So maternal risks and future pregnancy risks, right? Which is why people have moved to fetoscopic repairs. And at the moment, we're in the process of moving towards that. Right?
Okay. So are things improved because you've caught it at an earlier stage of development because of how long the effects have been there, or because it's happening before the baby is in the outside world, or is it some combination of those things?
It's a great question. And I believe what we think and what I think is that it's less exposure of the spinal cord to what we think is a neurotoxic environment in utero, amniotic fluid, basically.
Okay.
And so that would be the theory behind it.
Fascinating. And if a baby has surgery after they're delivered, what timing are we looking at there? How do you decide about that?
Yeah, it's usually within the first 48 hours of life. The data would suggest probably do it within 72 hours. We're almost always within that window here. And that's why we're on call as pediatric neurosurgeons, because we are here to serve and do that. And the risk is meningitis, right? So if you have the spinal cord and fecal sac and meninges exposed to the outside world, that bacteria can get in. And meningitis is a huge deal, especially if we have to put a shunt in. And especially in terms of long-term cognitive outcomes, they're going to be far less if you get a meningitis. So for these reasons, we perform the repair fairly quickly. We don't just whisk the patient off to the operating room right away because we want to make sure that their heart and lungs are healthy, get a good understanding of that, be able to risk stratify them and provide safe anesthesia and do the surgery carefully and thoughtfully. And to understand how big their ventricles are with a head ultrasound and just evaluate the baby for the first, 12 to 24 hours of life, essentially, and just have a good understanding of risk stratification.
And what are your goals at that initial surgery?
Yeah, the goal is to close the book. Everything is open, and we need to reduce the risk of meningitis. And so the way we do that is by literally recreating the different tubes that form in the body, right? So we just take the spinal cord, expose it very carefully, try to remove any type of skin elements that might be attached to it so that you avoid the risk of a future dermoid or epidermoid, which can then grow, like your skin sloughs off. And so if you have skin elements within your thecal sac, it can grow and then tether the cord down the line, which we'll talk about, I'm sure. And to close the spinal cord, to close the dura, and then to close the layers on top of that in as many layers as possible. The bone stays open, right? But all the tissues get closed. And sometimes, depending on the size of the body wall defect, we may or may not involve our plastic surgery colleagues. And so that's typically what the surgery entails.
It's like you're doing remedial embryology in a way, right?
Yeah, exactly. That's what, I never thought I'd learn so much embryology as a pediatric neurosurgeon. I kind of ignored that in medical school, but it's really important. And it's actually quite fascinating to understand it because it really lets you hone in on why this happened. And exactly as you say, try to reverse those steps as best as one can.
One of the things I find staggering as a pediatrician is how frequently things go well because there are so many points where things can go poorly. And
Yes.
the great thing about what you do is that something that's gone poorly then can be remedied. Tell me about the prospects. So how much better is life if you've had surgery? How do you change someone's outlook
Yeah.
about doing surgery?
Are you referencing
The rest of their life,
Yeah.
how their quality of life changes.
Yeah. So usually if it's a postnatal repair and a baby's been born with myelomeningocele, in a way, some of the damage has already been done, most of it, right? So we talked about sort of spinal levels and how that's relevant. The rest of it is to minimize the risk of meningitis and to place and treat a shunt if needed or treat hydrocephalus with some type of CSF diversionary operation, right, to help with that. And to support that child as they grow up. And that's why, in terms of our multidisciplinary spina bifida clinic, that there's so many other providers involved, orthopedic surgeons, neurologists, urologists, GI specialists, and physical therapists, social workers, and all of these things in order to help support that child because they may just require a way of adaptation in life, right? They may never urinate properly. They may have incontinence, right? And so our goal is to make them socially continent, right? And prevent UTIs and prevent renal injury and protect their kidneys and to support them as best as possible with their mobility. If that's a wheelchair, that's a wheelchair. If that's an assistive device such as forearm crutches or AFOs, then they get supported with that. And so it's just a way they're going to be born with certain limitations. I think that's what we tell most of our families with a child with spina bifida is that for the most part, we may be dealing with some type of limitation, especially with regards to bowel and bladder function, right? But other ways we can improve that child's mobility and quality of life, that's where this sort of constant evaluation comes into play, which is why I believe it to be more of a chronic disease than rather than a one and done surgery and we wash our hands of it and that's it.
But a real expectation of affecting both quantity and quality of life
It's possible, but the way modern medicine is and the way we've been treating spina bifida and myelomeningocele is many, many, many more of these patients are reaching the adult years.
Yeah.
And it's been a bit of a conundrum in our field or something that we need to resolve and be really thoughtful about and safe is who's going to take care of these children once they transition from the pediatric years. And so that's where adult spina bifida clinics and have sprouted out about the country.
Absolutely. Can we talk for a minute about every pediatrician's nightmare, and that's spina bifida occulta? Child who has presented after birth, and now we're reading gluteal clefts like tea leaves, trying to figure out what's going on. It's vital, right? We're looking for physical findings. We're all aware that we're looking for sacral dimples and hairy patches and any things that are different there. Tell us what we should be most keyed into so that we don't miss something big.
I think the way I would think about things is sort of grouping dimples simply as those that occur above the gluteal crease and those that are sort of within or, within the gluteal crease. If you push down on a pit within the gluteal crease and you feel the sacrum or coccyx or tailbone, usually we're not concerned. That often does not merit further evaluation, right? So an MRI would probably be overkill, although an ultrasound can be useful, and we can talk about that. Dimples above the gluteal crease, whether they're midline or not, or whatever they look like, we'd probably want to know about that. And so many times, infants, we have the ability to do an ultrasound on them. And that's usually within the first 6 months of life before things ossify and is less useful. That's a limited evaluation. There's a fairly high false positive result with an ultrasound. But if there's a dimple above the gluteal crease, I think that merits further investigation. That's the main thing, because what a sacral dimple could be is a dermal sinus tract that goes from the surface of the skin all the way into the fecal sac and can theoretically cause a meningitis, which is obviously terrible, right? And so that's the big thing we're trying to avoid. So, alarming symptoms, things to look for, is there drainage or just the appearance of it? And if it's more than just a dimple, if it's a dimple plus, I should say, that probably merits further investigation, like a hemangioma, a vestigial tail, any fatty mass, lipomatous mass or fluid-filled space that you feel in that area. And of course, any neurological signs. Those are all reasons that we'd want to know about fairly quickly.
Is there anything helpful about shape of the dimple?
Not really. I
Okay.
think that they come in all shapes and sizes, and we've seen a little bit of everything here, and so I think it's more location rather than shape.
What about the gluteal clefts that seem to extend for a longer period of time? Sorry, for more geography, so that instead of terminating where you think they might, it seems like it continues a little bit farther up. Is that worrisome?
That's a good question. I'm not entirely sure. This is where some of the gray areas come into play in our field.
Mhm.
And, just a cleft that goes up without a dimple, probably okay. But anything else, any of those other cutaneous manifestations, you mentioned the obvious ones, but any dimple, any hairy patch, obviously, or any hemangioma, or we call it kind of grotesquely, we call them cigarette burns, where it kind of looks like a ashy spot, on the skin where it's a little bit thinner or almost like a cutis aplasia. Any of that stuff warrants further investigation. The cleft itself or the crease going up higher, I'm not so certain about that.
Okay. We get calls from the nursery about that sort of thing. So just
Gotcha. Yeah, I can imagine.
going back again briefly on the timing, obviously, if we see anything that suggests drainage, that suggests an open track, that's an immediate
Yes.
talk to you guys. And as far as getting an ultrasound, if we're a little worried but not a lot, what sort of timing are we looking at there?
Ultrasound, is a nice gimme because it's not invasive, it's fast, it's not extremely expensive compared to an MRI, and usually it doesn't involve sedation and anesthesia. And so that's one where if there's a dimple that's sort of borderline or something, or you're just not sure, it's a very useful screening tool. And that's the way I think about it. I never make a clinical decision just based on an ultrasound. If there's something on an ultrasound, it oftentimes would pick up the really serious things, if there's some real true serious anomaly, and then we further characterize it on MRI. That's why I think it's a useful screening tool, but within the first 6 months of life. Beyond that window is sort of not as useful. And so if there's doubt, and sometimes, I've sort of changed my practice a little bit, I would say get the MRI and I'll see them. But now I think that sometimes if we're in a bit of a gray zone and we're not sure and the child's doing just fine neurologically, it's worth a visit with us just to talk about things so that we can use a shared decision-making approach about when to get an MRI. Because if there's no concerning findings, we'll often wait until the 4 to 6 month point anyway to get the MRI. Just because they're older, the anatomy's clearer, they're just beefier, and there's more tissue to look at. And that's when we would consider, the earliest point where we might consider intervention, or at least a conversation about intervention.
Very helpful. Is there anything else you wanted to mention about spina bifida before we're done talking?
Just that I think that it comes in a lot of shapes, sizes, flavors. It's a really confusing term. It's really hard to research this. I have patients come in who are extremely worried about something coming in. They read all kinds of stuff and they might have a coccygeal pit, and so I think it's I think the field should know, both the field of pediatrics and reflecting on our field, pediatric neurosurgery, that there's confusing terminology and it's very inconsistent. And that the clearer we can make it for our patients, I think the better it is.
That's very helpful. And as we say on this podcast all the time, things are so much better when we communicate. You know, that if I'm concerned and I'm not exactly sure what to do, because I worry about this all the time, but I confront it a small amount of time. And so when in doubt, it's probably not a bad idea both to know that I can call somebody like you, and that sometimes talking to a radiologist can be helpful too, and say, what should I add to do?
Absolutely. I agree. Collaboration with radiology. And if you're at all concerned, just send them our way, and we'll continue the conversation and hopefully be able to allay any fears. And if there's something that warrants further investigation, help guide those decisions.
Perfect. And if somebody wanted to contact you, how would they reach you?
Our pediatric neurosurgery office. I'm happy to provide that contact information. It'd be clinic number is 801-662-5340. And if there's ever any questions about tethered cord, scoliosis, spina bifida, myelomeningocele, any of these things, then my email, which is Rajiv, RAJIV, .Iyer, IYER, @hsc.utah.edu.
Excellent. Well, thanks so much, Rajiv. This is fascinating. And it's the sort of thing I think we've all sort of thought about before, but I think you really pull it together very nicely. And I really appreciate your time and expertise in doing that.
Thank you so much for having me. It's a pleasure to speak with you.
There are bound to be good questions out there. Please feel free to send your questions, as always, to questions@vcurb.com, and we'll deal with those in a couple of weeks. You'll come back next week and we'll talk about tethered cord?
Absolutely. I'll be back.
Excellent. See you then. Thanks, Rajiv.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.